Good day, everyone. We are the RLE Group 2 from Block NF, and today we will be discussing about this concept map on the topic of the Hirschsprung disease.
By definition, congenital ganglionic megacolon, also called as Hirschsprung disease, is a condition in which certain nerve cells, called ganglion cells, are missing from the muscle layer of part of the large intestine. The ganglion cells function to allow the bowel to relax. Without the ganglion cells, the bowel remains constricted and narrow. This means the child is unable to move stool, which causes severe constipation or blockage of the large intestine. During the 8-week gestation, fail to arrive in the proximal colon. This results to further absence of enteric neurons within the myenteric and submucosal plexus of the rectum and/or colon. With this, the peristalsis or the muscle contraction is affected, thus leading to an obstruction of the colon, which may lead to accumulation of gases, feces, until it results to enlargement of the colon or the megacolon. The exact causes of Hirschsprung disease is unknown, but genetics have been found to play a role in its causation. The following are identified as predisposing factors of the disease. First is genetics. Around 20% causes of Hirschsprung disease occur in multiple members of the same family. It appears to have a dominant pattern of inheritance, so only one copy of the altered gene may be sufficient to cause the disorder. It is incomplete penetrance. Second is being a male. Hirschsprung disease is more common in males. Third is family history of the disease. Hirschsprung disease can be inherited. Fourth is Down syndrome. Hirschsprung disease affects 1 in 100 children with Down syndrome. Down syndrome is the most frequent chromosomal abnormality that is associated with Hirschsprung disease. And lastly, genetic heart condition. Children with genetic heart conditions have an increased risk for Hirschsprung disease.
So far, there has been no conclusive evidence to back the claim that medications or certain diets during a woman's pregnancy may cause Hirschsprung's disease. Possible factors, however, may include selective serotonin reuptake inhibitors, SSRI medication used to treat depression taken during pregnancy was shown to be significantly associated with the development of Hirschsprung's disease in newborn children. Second factor is mother's diet. While not explicitly the cause of Hirschsprung's disease, the mother's diet may lead to other congenital conditions, including heart defects, that make the baby more prone to developing Hirschsprung's disease. A diet rich in vegetables, fruits, iron, folic acid, and other required prenatal vitamins, and low and high-calorie food and snacks was shown to lower risk in the baby's development of congenital heart defects. Some infants with Hirschsprung's disease have signs and symptoms of intestinal obstruction shortly after they are born, including not having a first bowel movement within 48 hours after birth, green or brown vomit, swollen abdomen or belly, problems feeding, explosive stools or diarrhea after a doctor inserts a finger into the newborn's rectum, and lastly, symptoms in older infants, children, and adults. Some children with Hirschsprung's disease with no signs or symptoms at birth may not be diagnosed until they are older. Common symptoms in older infants and children include chronic constipation that doesn't get better after treatment with oral laxatives, gas, fatigue, and lastly, malnutrition or failure to thrive, meaning that an infant or child weighs less or is gaining less weight than expected for his or her age.
The major nursing diagnoses for Hirschsprung disease are the following: constipation related to decreased bowel motility, imbalanced nutrition, less than the body requirements related to anorexia, fear in terms of the older child related to impending surgery, risk for impaired skin integrity related to irritation from the colostomy, acute pain related to the surgical procedure, deficient fluid volume related to post-operative condition, impaired oral and nasal mucous membranes related to NPO status and irritation from the NG tube, deficient knowledge of caregivers related to understanding of post-operative care of the colostomy. The following are the management for Hirschsprung disease. For the medical management, we have the initial therapy, which includes intravenous hydration, withholding of enteral intake, and intestinal and gastric decompression. Second is decompression. It is a placement of a nasogastric tube and either digital rectal examination or normal saline rectal irrigations for 3 to 4 times daily. Diet. Pre-operatively and in the early post-operative period, infants on a non-constipated regimen such as breast milk are more easily managed. When it comes to pharmacological management, we have the antibiotics. Administer broad-spectrum antibiotics to patients with enterocolitis.
For the surgical management, leveling colostomy. A colostomy at the level of a normal bowel. A staged procedure with placement of a leveled colostomy, followed by a pull-through procedure. Single-stage pull-through procedure may be performed with laparoscopic, open, or transanal techniques. This procedure can be performed at the time of diagnosis or after the newborn has had rectal irrigations at home and has passed the physiologic nadir. For the nursing management, promote skin integrity. Give careful attention to the area around the colostomy. Prepare the skin with skin toughening preparations that strengthen it and provide better adhesion of the appliance. Promote comfort. Observe for signs of pain. Additional nursing measures that can be used are changing the child's position, holding the child when possible, stroking, cuddling, and engaging in age-appropriate activities. Maintain fluid balance. Accurate intake and input, determinations, and reporting the character, amount, and consistency of stools help determine when the child may have oral feedings. Provide oral and nasal care. Perform good mouth care at least every 4 hours. Provide family teaching. Show the family caregiver how to care for the colostomy at home. The diagnosis of aganglionic megacolon is made through the following data. Rectal manometry. In older children who present with chronic constipation and an atypical history for either Hirschsprung disease or functional constipation, anorectal manometry can be helpful in making or excluding the diagnosis. Unprepared single contrast barium enema. An unprepared single contrast barium enema may help establish the diagnosis. The study may also reveal a non-distensible rectum, which is a classic sign of Hirschsprung disease. Plain abdominal radiography. Perform this test with any signs or symptoms of abdominal obstruction. Laboratory studies. CBC count is ordered if enterocolitis is suspected. Elevation of WBC count or bandemia should raise concern for enterocolitis. Rectal biopsy. Diagnosis is confirmed through rectal biopsy.